these things don't work as well for me. Oh, can you hear me okay? Oh, great. All right. Well, that's easy. I have to begin with, it's nice to see some familiar faces in the audience, all but one. And I'm having flashbacks, and not from what you might think. Okay, thanks. That's helpful. Let me put this on. Is that better? That's better? You can hear me okay? So I'm having flashbacks because of one person in the audience, and that's, I was a fellow in maternal fetal medicine about 24, 25 years ago, and I had to take a course in reproductive epidemiology. And my final exam was to debate the professor. The professor was Ben Sachs, and the subject was home birth. And he may not remember this, but he assigned me pro-home birth during the debate, and I passed the exam, if that helps you a little bit, but I feel like I've been called before the dean to repeat this 25 years later. So I do have some disclosures that I think are important. I am an obstetrician, and my salary varies with the number of in-hospital deliveries that I do. I am a fellow of the American Congress and College of Obstetricians and Gynecologists. I am the past chair of the Committee on Obstetric Practice, and I was the primary author for the Planned Home Birth Committee opinion. And before you get too concerned, that doesn't mean what you think it does. And currently, I am the medical director for a large hospital-based midwifery service. And until the implementation guidance comes out from Massachusetts, I'm the supervisor, but that title will go away as soon as we hear how they want to implement the new law. So I would like to do a couple of things today, and this feels like to me it's coming in and out. Does it? Okay. I would like to describe one professional organization's use of data for decision making. And that's ACOG. That's what I think that's pretty much why I'm here today. I would like to describe the limitations of existing data sets, talk about what I think would be an ideal data set, although after listening to some distinguished colleagues yesterday, I think I might end up adding to that ideal data set. I would like to just briefly review some very good but still not quite perfect data sets that are out there, and then finally talk a little bit about something discrete, pragmatic, and doable that we could achieve. I don't know how many of you in the room have read this. This was required reading in my, my government class in college at the Air Force Academy. And this was the narration of one bill getting through Congress. Does anybody remember what the bill was? This created the National Health Service Corps, but it was quite a narration. So I've always loved this book, even though I'm not crazy about the business of politics, but it seemed very parallel to ACOG getting the committee opinion out. So if you will, I think what we'll do is go through the dance of a committee opinion. This was where it began. This was the state of affairs when this effort began. And this is not a committee opinion. This is a statement of policy issued by the executive board of the college, not one of the practice committees. And you can see, we can read through all the details, but there are some lightning rods in here. ACOG strongly opposes home births. ACOG does not support programs or individuals that advocate for or who provide home births. So that's where we started. And part of the reason was there was not a whole lot of data to inform the issue, and this was the position of the college at the time. Dr. Jerry Joseph, who's now the Vice President for Practice Activities, had an initiative that involved improving our collaborative relationship with midwives in general. And part of it was to say it's time to relook at our position on home birth. So of course it would freeze on that slide. Guidelines for Perinatal Care is really a sort of a legacy document published every so many years by the American Academy of Pediatrics and ACOG, but it's really fueled, fed by other documents. And so the statement from the executive committee was what fueled the 6th edition of Guidelines for Perinatal Care. And you can see that we had our standard language about where we as an organization felt the safest place for birth was. And down here, until such data are available, home births are not encouraged. So this was in an environment where in 2006, this was the number of home births in 2006. If you cut that by 1/3 and say 2/3 of those are planned, 1/3 are unplanned, it's about 0.38%. But that number, it's hard to grasp that. For me, I understand in my numeracy concept, I understand 1 in 263 better for planned home birth. So it was in that environment that this effort began. It was fueled by, I think that prior statement was influenced by what was out there. We heard yesterday that some of the work that fueled that opinion was controversial. We heard Kate Finn yesterday give a fairly emotioned feel about her take on it. And I suspect that's shared by a number of people in this room. But then the tides began to change. I'm not sure what I'm doing wrong with this. Okay. So I'm not going to go through all the data in a granular fashion. We don't really have time. But what I do want you to do is pay attention to study design, data source, and where it came from, because that's important. I think that's really what I was asked to talk about today. So this one, although no difference in neonatal death, this was a retrospective cohort study from the Swedish Medical Birth Register, and I put the plus mark there because it wasn't just their equivalent of the birth certificate. They actually then made phone calls to follow up on this. So this was, you might think of it as birth certificates plus. But this was somewhat encouraging that home birth might not be as bad as what other publications had suggested. The next one, De Jong and colleagues, I know you are familiar with this one. Again, retrospective cohort study, a national perinatal database, which was actually 3 different linked files out of the Netherlands, again, suggesting that home birth was not associated with terrible outcomes, that it was actually associated with reasonable outcomes. Jansen and colleagues, a retrospective cohort study from a provincial perinatal data registry out of British Columbia. So we can talk about that later, but a little bit of it depends on, it's prospectively collected data and retrospectively analyzed. So that's part of the language that I think gets confounded a lot when we talk about these. So we'll have an opportunity, Sarah said, at the end. Similar thing. What they began to show was that, like the common theme in all of these, was that medical interventions are decreased with home birth for comparable groups of people. This one again showed newborn outcomes that were relatively the same. I don't know if I'm losing a battery here or what, but I'm about every 5th click advancing. Hutton and colleagues, another one. So this was a retrospective cohort study, Ministry of Health database for midwifery care out of Ontario, Canada. So there was the PANG study, and then this sort of wave of observational studies that suggested it's time to relook at home birth. There's more data than there was when the executive statement was published. Different organizations had different takes on this. Some would come out for home birth, others were coming out against home birth. And so this is where we get into the dance, and this is what I thought I would narrate for you. How do we get to a committee opinion? The subject is proposed to the committee, and there are many routes to get there. That can come from individual members of the committee. It can come from correspondence to the college. It can come from public members who are concerned. It can come from representatives, elected officials, There are many, many different reasons, but they are proposed to the committee. The committee then decides it's worthy of going forward. A primary author is assigned. A professional literature search is conducted. You have about 6 months to prepare the draft. And so the primary author is sort of the one that takes a first pass at this. At the next meeting, 6 months later, if we meet the deadline, 12 months if we don't meet the deadline, it's discussed by committee. And the committee is made up of ACOG fellows, representatives from the American Academy of Pediatrics, American Academy of Family Practice, ACNM, NICHD, CDC, SMFM, and ACOG staff. And this is a humbling experience. Your work in front of around a table of respected colleagues is basically shredded and put back together, way more than any manuscript I've ever participated in. It's a very humbling, long day, to say the least. So then all of those comments are sort of assembled by the staff at ACOG, presented back to the primary author. You have about 6 months to revise it. It's then put back to the committee. If it clears the committee, it goes to the clinical document review panel, a separate group of people that look at it for internal consistency, data. Is it consistent with other documents published by the college? And you can see that if this one went forward, it's going to conflict with the statement of policy, which would end up having to be pulled. If it clears the clinical document review panel, it then goes on to the ACOG Executive Committee. They all have input into it. It's then published. Once it clears that, it's published in Obstetrics and Gynecology and online. There's a press release. And then importantly, different than a statement of policy from the Executive Committee, this one has a lifespan. So once it becomes a committee opinion, it is regularly reviewed for important changes to the data, to contributions to the subject and the science. So it's no longer just a statement of policy. It becomes a living document with regular opportunity for review and input. Well, during this long process, the meta-analysis came out by Dr. Wax and Panett and colleagues, Dr. Wax and Lucas. And I think sometimes what gets lost in this meta-analysis is that it showed dramatic reductions in all the interventions that we have at our disposal in the hospital. This is what got a lot of people's attention. According to the authors, a twofold increase in total neonatal deaths and almost threefold increase in non-anomalous deaths. And I understand that even by me standing here saying threefold, when it's 2.87, will be an emotional thing for some in the room. It's not threefold, it's 2.87. So it's such an emotionally charged subject. Well, that's an understatement. I call this in the wake of a meta-analysis. And I got to live through this, but the response from many, some in the room, was fairly dramatic. Letters to the editor in other journals, even a couple of letters to the editor in BMJ, letters to the editor in Lancet, popular blogs picked it up, non-peer-reviewed but well-read websites. This was I don't need to tell any of you in the room, this was quite a dramatic course of events. And this was the point where I basically had to tell my children, don't Google your father for about 2 years. Okay, I'm really, is there a keyboard? Yeah. The keyboard's not working. Well, it's a little frustrating. Great. Thank you very much. So This was not missed on the editors of this journal. They received numerous letters to the editor, and a number of them were published. And then they took, as we heard yesterday, took the very unusual step of reconvening a panel of experts in meta-analysis. Granted, they were all maternal fetal medicine docs, which may make a difference on who does a meta-analysis. But the editors took this very unusual step, and they gave them all the data and said, please redo it independently and tell us what you get. Retracting an article, which is what was called for by some of the writers to the editor, is not a popular thing to do. So what they concluded was that in all three cases with the independent review, the panel results were slightly different from the result in the manuscript, although there was no difference in the direction of the point estimate of the pooled odds ratio or the overall statistical significance of the result. The panel made the following recommendations. The journal should publish online full summary graphs or the forest plots, and there was no need for retraction of the article. So we went forward with the committee opinion, the new committee opinion, and this is just the abstract from the committee opinion. And again, remember, this is an opinion from an organization, not one person. And how it is drafted, including what's emphasized in an abstract, is our organization's opinion, but still a little bit of a lightning rod for some in the room. We were in the midst of rewriting guidelines for perinatal care, so the new committee opinion, including those remarks about what we now thought about home birth and its risks and benefits and requirements for conduct of safe home birth went into guidelines for perinatal care. So what I can tell you from a personal perspective in all of that is that the process is, again, way more rigorous than standard peer review, an order of magnitude more rigorous than standard peer review. But it is written from a US perspective, and there is tremendous regional variation in our infrastructure around the country. And I'll show you a slide in just a second that emphasizes that. Similarly, we are writing for a US audience. And so we have to be careful that we use cautious use of data from outside the US. It is carefully worded to try to avoid ambiguity and overstatement. But in the end, this is the bottom line. It remains an opinion. I mentioned differences in infrastructure. This is a new bit of information you can get online at the college. And what this shows you is driving time to a maternal facility. And this is from the American Hospital Association. This is not an ACOG. This is not where ACOG fellows are. This is where maternity services are. And if you see white, that means that the driving time to a maternity facility is over an hour. So you can see that when we are writing for a country, we're not writing for one particular area that's really got their act together. It just really may not apply broadly around the country. This is a friend of mine. I was lamenting, I felt a little bit whipsawed back and forth with this course of events. And in trying to calm me down a bit, Jeff, who's my partner and colleague at Mass General, said, Bill, in the end of the day, and he ended up saying this at our recent SMFM meeting, no one can force someone to have a hospital birth. No one can force providers to support home birth or interpret data differently than they do. And that's not ethics, it's not decision making, that's reality. And I think as we go forward as colleagues, remembering that there are some realities, like it or not, that we're going to have to deal with is important in how we work together. So in the environment, this is only continuing to go up. Marianne presented this data. I took the liberty of trying to see if I could update it, and it is still going up. This is from 2010. Now about 0.79, and if you do the math on that, that's I think 1 in 163 now if you do the 2/3. So I like this, and for me personally, living through using data for decision making, this was a good compass for me. And this is from Carl Jung. And it was that rational arguments can be conducted with some prospect of success so long as the emotionality of a given situation does not exceed a certain critical degree. If the affective temperature rises above this level, the possibility of reason having any effect ceases and its place is taken by slogans and chimerical wishing. So for me, That just says, okay, stay calm. Let's talk as colleagues that respect each other. Let's try to keep the emotion, although that's very valid, keep it out of this as best we can. So what do I do when my affective temperature is up here? I find comfort in data, so I try to go to the data. So on this subject, what is the data that has been used? It's almost exclusively observational. Most is retrospective, some prospective. Sarah's mentioned I may have we may differ a little bit on that. Okay. Comparison groups, as Dr. Waterberg mentioned yesterday, in any observational study are inevitably different in some ways. Some we can tell, some we cannot tell, but they are different. And we're not going to have an RCT on home birth. The one that was tried only accrued 11 patients. So what's out there? We have birth certificates, the 2003 standard certificate of live birth. We have state-based reporting. We have a couple of respectable efforts here that are maturing and getting better and better, and I'll describe those a little bit. We have data sets that from any of the individual studies and then from payers. This is my ideal data set. If I was going to say, I want to go to a meeting on home birth and have the perfect data set to sit down and calmly resolve the issue, this is I'm sure after yesterday, a subset of what this room would come up with, but I think this is huge and on the top of everybody's list. Intended place of delivery is vital. Selection criteria, I think we would all agree. Appropriateness, was this an appropriate candidate for home birth? And we don't all agree on whether that should be, are there antepartum features or intrapartum, but our data set should inform that. The type of attendant, education, certification, and licensure. Right now, we can't really get down granularly enough on other midwives, as I'll show you. We don't know, we can't separate that out perfectly yet. Integration of the health system, we would like to say whether there were transport agreements, how far was the geography, what was the indication for transport, and then ascertainment of outcomes. We should try to use the same language on what we mean by neonatal death, stillbirth, early neonatal death, late neonatal death. There is a project that some in the room, I think Dr. Main will talk about this in a moment, but the Revitalize project was more than 80 organizations involved in data collection regarding this, regarding reproductive health in an attempt to use the same language, which is wonderfully encouraging. Ideally, we should all have one electronic record and we just plug our thumb drive into the person we hand off to. That would be perfect, but we're not there. Mandatory, audited, and enforced reporting. I don't mean reporting of adverse events. I mean reporting in the data set. So it should be compulsory, whatever we do. We shouldn't be able to report this one and not that one. And then finally, I think it should be publicly available for download and analysis. So where are we with birth certificates? Marion McNorman, in a very gracious phone call, updated me that now 36 states are using the U.S. Standard Certificate of Live Birth. DC, Puerto Rico, the Marianas are, and a number of states are also using this number are using this standard report of fetal death. That, as you will see, will become important. I suspect this may be a little bit lower because when we start talking about fetal death, we end up overlapping another very emotional issue that states feel very passionately about. But I would like you to know that ACOG has been pushing this hard for 10 years, so much so that we wrote model legislation in 2009, distributed to all the states. We pushed it out at every opportunity we could for public comment. It's in the encouragement is in guidelines, and this is what Marion referred to. We believe that the agreement between NAFSIS and the NCHS that all states should be using these common certificates by January of next year. There's some muscle behind that, some funding or some penalties potentially. So when we talk about the birth certificates and what they don't do, this is important. What it does not do is capture planned home birth transferred to the hospital. So if you deliver in the hospital, it's hospital. There's nothing that says plan to deliver in hospital. It doesn't say that here. So we're not capturing planned home birth that delivered in the hospital. Other midwife I mentioned, we're not distinguishing between different routes to midwifery. And then none capture the reason for transport to the hospital, and that's really important. The death certificate, same kind of thing. Does not capture planned home birth, doesn't distinguish provider. And then down here, if there's an intrapartum death, it doesn't say intrapartum death in the home or intrapartum death in the hospital. So these are very specific things that are within our reach to just tweak. Again, with a very nice phone call with Saras and Missy Cheney, described for me the current Manistats effort. But enrollment in Manistats is voluntary. Participation rates of about 20 to 30% of CPMs currently participate, about 17% of CNMs. Individual patients have to consent, only about 3% decline, less than 3%. About 8% in the one version didn't finish the registered event or course. CPMs use it more than CNMs. There has been a progression of versions, more and more sophisticated and more comprehensive. Efforts are underway to encourage mandatory reporting. And I asked Saras and Missy, if there was one thing you could fix about Manistats, what would it be? And in unison on the phone, they said compulsory reporting or mandatory reporting. And then I have to mention this. I would love one of these. They came up with this thing to ensure quality. They have something called a data doula that helps the data get in, which is... there is a publication using Manistats back in 2005. Here you can see the outcomes are similar to what's been published in other studies. Birth center. This is not just about home birth. This is about birth settings. I can say I knew her when. Kara Osborne and I used to work together. But this is their recent publication on birth centers, using standard data sets about outcomes. But here, only about 41% of birth centers are known to be members of AABC, and only about 80% of those participate in the online registry. So again, you can see that for both of these very elegant, very well-intended data sets that are maturing and getting better, the biggest issue would be participation. So other sources, University Health Consortium. I've heard people call this NPIC, but the National Perinatal Information Center. I'm not going to talk about CMQCC. That's for Elliot to go over if he would like to. Payer systems, HCA, Kaiser, Intermountain Health, the DoD. Some of these are huge data sets that are available. And then there's a sort of a fledgling effort just starting, the Women's Health Registry Alliance, which is sponsored by ACOG and a couple of others trying to collate data sets. So, but my talk was supposed to be on the use of data for decision making, and I have just a couple of slides. It depends on who's making the decision, and each of these interested parties will have a different perspective and different values. So how we use the same data will vary. We value different outcomes differently, potentially. I have on purpose not discussed the ethics of decision making. That would take a whole conference. I do like this one though, and this is Noam Chomsky. As soon as questions of will or decision or reason or choice of action arise, human science is at a loss. Dr. Armstrong yesterday would maybe not agree with this, but I don't think I agree perfectly with it either, and I think that we can have a way forward. But unfortunately, right now, what we're left with is no RCTs of sufficient size to inform the subject. We have only imperfect case series and cohort studies that have ascertainment problems. We don't know about uniformity of the provider, non-standard selection criteria, different variations of outcome, and great, tremendous regional variation. And ultimately, we have no uniform data platform that spans birth settings. Home birth, Manistats is probably the leading contender. The AABC is probably the leading contender for birth centers right now. But I must admit, we don't have a uniform hospital-based delivery system either. The best shot, I think, that spans and that's very doable is the birth certificates. And here, I think we should all continue to encourage the states to adopt the 2003 standards. It's like running a marathon. We're almost there. We should encourage to push that last 4 miles. And then finally, we need minor modifications to the 2003 reports that specifically address intendedness, the attendant, risk stratification, care process such as transfer and geography. I think that concludes what I wanted to say.
Thank you. That was very informative. And hopefully we'll have an opportunity to discuss your presentation later on. But for now, I'd like to introduce Caitlin Cross-Bynett. She is a social science research analyst at the Center for Medicare and Medicaid Innovation. And she's an associate at the Johns Hopkins Bloomberg School of Public Health. She's going to tell us about some of the work that the Center for Medicaid and Medicare has been doing on looking at birth settings.